Welcome to AETCM, the Emergency Medicine channel. Today we'll discuss about how to read X-rays, especially chest X-rays. This is the most common problem we are facing in emergency room because we have no official teaching for X-rays in most of our curriculum. So we'll learn how to read a chest X-ray properly. Now, you know that we have two types of X-rays taken in emergency room. One is normally we take X-ray PA view. You can see here the X-ray beam come from here posterior anteriorly. That is PA view. But in AP view, the patient will be lying down on the bed. The film will be taken here. Beam will come from the top. That is AP view. So normally we take a PA view. So in a PA view, we have to see certain things to know whether the X-ray is properly placed or not. So the most important thing what you can see here, the clavicle. Both the clavicle should be equidistant from the central. The flame-like thing is spinal process. So from there you can see the distance is same. That is the most important thing. So first one is position. If position is not equal or not normal, suppose this clavicle is here and you are seeing this clavicle is here, it is completely rotated so that this area will be compressed. So this lung area may be compressed. So that is not a good film. Always look at this like equality of both sides. That is very important. Then you can count the ribs from 2 to 10 ribs. Normally we see in a deeply inhaled X-ray and see that all these ribs, any like suppose you see a space of there is a lesion in the bone. That all things we have to document. Fractures, malignancies, infiltrations, all these things you can see. Then look at the heart. If you take an X-ray, air will have black color. So here more black color is there. Inside lung contains air, so it will be black in color. But heart contains blood. So that will be in white color. So you have to see the heart, whether cardiomegaly is there, all these things you have to see. And you can see the apex of the heart. This is the apex of the heart. Sometimes what happens is when there is a cardiomegaly, the apex will be like this. Heart will be like this. So there will be cardiomegaly. So this is the apex of the heart here. Then what you are seeing here is diaphragm. Two diaphragms. And most of the time, the left diaphragm will be slightly lower than the right diaphragm. That is because the heart is sitting on the left diaphragm. That is very important. Don't think that right diaphragm is elevated because liver is pushing it up. It is because the heart is sitting on the left diaphragm. That's why it is lower. Okay, so that is very important. So all these things are basics. We'll go to the next slide. We can see other things how to read the X-ray. Now, the most important thing is exposure. So here you can see the exposure. So some X-rays, it will be equal to the black color outside. That means the lung contains more air or it is underexposed. So more air means conditions like COPD, asthma and all, there will be air trapping inside the lung. So that part of the lung will be more blacker, or that type of X-rays will be blacker than the normal person's X-ray. So exposure is very important. Now we already told that diaphragm is always down in the left side. Hilum will be slightly upper in the left side. Now heart also we have to check whether the cardiomegaly is there or not. So normally if you take the transthoracic area, so suppose it is 20 centimeter, so you can see the heart like this, the total area of the heart, it should be half of the transthoracic area. So the 20 centimeter is here. If the other one, cardiac area is 10 centimeter or less than that, then that is good. Suppose the total area is 20 and the heart area is 15, that indicates cardiomegaly. So cardiomegaly also can be picked up from a chest X-ray PA view, not from AP view. AP view, what happens is the diaphragms, both the diaphragm go up and the diaphragm may compress the heart and there will be normally cardiomegaly. So that doesn't mean that patient is having cardiomegaly, only because of the diaphragm going up, the heart is enlarged. So the right diaphragm is always higher and left diaphragm is lower. That is because the heart is sitting on the left diaphragm. That is very important. Heart is sitting on the left diaphragm. Suppose you are seeing one diaphragm is unusually high. So that may be like enlargement of liver, some other mass or collapse of the lung here. All these things can produce unusual elevation of the diaphragm on the right side. Otherwise, there will be minimum elevation of nearly 3 centimeter, up to 3 centimeter elevation can be there. Now you can see the trachea. Normally you can see the trachea in the middle part between the both clavicle. Sometimes what happens is if there is a lesion here, like tuberculosis, it can drag the trachea towards this side. So what happens is trachea may be dragged towards the main trachea will be dragged towards that lesion. Sometimes what happens is there is a mass here, huge mass here, that can even push the trachea to opposite side. All these things we have to document. Now always look at the bones because lytic lesions can be there in the bones, like in multiple myeloma or other malignancies, prostatic malignancies. All these things you have to look for the lytic lesions and fractures. Some patients can have severe cough or chest injury, they can have small fractures in the rib. Okay, so they'll be having severe pain on deep inspiration. In that condition, you have to ask the patient to lie down on that side and reduce the movement of that side. That is a treatment, or painkillers can be given. Now, soft tissue enlargement, sometimes you can see that also should be checked. Like suppose here you have a soft tissue enlargement. So that may be lymph node or something, that also can be looked. And always look at the media channel. There sometimes you can get lymph node enlargement. Then you can see this is aortic knuckle. Then pulmonary bag is there. Then left ventricle. Like that you can see all the features. And always look at the area under the diaphragm. Sometimes what happens is if there is air under the diaphragm indicates some perforation in the stomach. Okay, so that also should be checked. Now basically chest X-rays are divided into APV or PAV. They are divided into 3 zones. We cannot comment which lobe is involved from a single chest X-ray, but by experience you can sometimes tell which lobe is involved. But most important thing is in an X-ray upper zone. You can see the first 2 ribs, that is upper zone. Second or third 2 ribs are mid zone. Last 2 ribs can be lower zone. Okay, so if you can make the diagnosis as upper zone pneumonia, mid zone pneumonia, lower zone pneumonia, or upper zone mass, mid zone mass, lower zone mass, that is the actual method to tell the lesion. Where the lesion you can easily write. But if you write upper lobe pneumonia, lower lobe pneumonia, sometimes it can go wrong. That's why we don't use that terminologies. We can use upper zone, mid zone, lower zones. Now, you should know the structures in each zone, then it will be very easy to comment what is the structure which is enlarged there. For example, here you know that mid zone is the like mediastinal tumors, lymph nodes, aorta, all these things come in the upper zone and the mid zone. Okay. Now, if you have a cardiomegaly like that, you know that it is a heart which is enlarged, that is predominantly seen in the lower zone. Suppose you have a pneumonia here, consolidation here, you can tell right upper lobe consolidation. So like that we can tell which organ comes in which zone, and you can make a probable diagnosis from that. Now look at this X-ray. There is a white homogeneous opacity on the right upper zone. We cannot tell which lobe it is. To tell which lobe, you have to always take a lateral X-ray, or you can go for CT scan. Here you are seeing a right upper zone homogeneous opacity, which is round opacity. So most of the time, this type of lesions can be seen in malignancies. So it can be due to malignancy, or sometimes if there is a small cavity here, then it can be even a fungal mass also. Okay, but here mostly it is a malignancy. But the same type of lesions or same type of white patches can also be seen in pneumonia. So pneumonia is also possible. Depending on the clinical symptom, you can tell whether it is a pneumonia or mass. Suppose somebody is having a chronic smoking history, is having weight loss for last 6-7 months, and he comes with this type of X-ray, you cannot tell this is pneumonia. You can tell this is possibly malignancy. But this patient come in last 3 days, he is having severe cough, breathlessness, and this lesion can be pneumonia. So like that we have to tell. But this is a right homogeneous opacity on the right upper zone. But if you want to see which lobe is involved, you can always take a lateral X-ray. Nowadays this has got less value. We rarely take lateral views because it is not going to change our practice depending on the clinical scenario, clinical examination. You can easily make out whether it's a malignancy or pneumonia. Whatever it is, if it is a malignancy, we always need a biopsy to know what is the type of lesion, and that requires a HRCT also. Now this is a upper lobe white lesion. You can see here uniformly there is a homogeneous opacity on the right upper and mid zone. So you can see this is upper zone, this is mid zone. So both upper zone and mid zone there is a homogeneous opacity. It can be pneumonia. Why it can be pneumonia means this looks like an acute inflammation. Your interlobar fissure is sagging down. When the interlobar fissure is sagging down, that indicates some edema. The edema is there, that's why it is sagging down. This is mostly seen in pneumonias. But if it is a tuberculosis lesion, suppose it's a tuberculosis lesion, most of the tubercular lesions are like they are chronic and they produces loss of lung volume, and interlobar fissure may go upwards. That next X-ray we can see. So this looks like a upper lobe consolidation. Now always look at this whenever we are seeing a white patch like this. Always look at the trachea. If it is collapsed, trachea may deviate to this side. Okay. So here the trachea is not deviated to right side. It is not deviated to right side. Trachea is in the middle part, and you see the rib spaces. All the rib spaces are normal like opposite side. Suppose it's a collapse, there will be collapse of these rib spaces. Rib spaces are not collapsed and trachea is not deviated to this side. So it looks like a consolidation. Upper lobe consolidations are mostly due to Klebsiella pneumonia. But look at this X-ray. It's a chronic process. Here the loss of lung volume is there. The interlobar fissure is dragged upwards. The trachea is totally deviated towards this side. So this can be fibrocavitary lesion, mostly seen in tuberculosis. So fibrocavitary lesions are lesions which are produced by either fungal infection or tuberculosis. They produces loss of lung volume. So the interlobar fissure has gone up and the trachea is deviated to the same side. So we should remember that. Now collapse also can produce sometimes same type of lesion. Suppose there is a consolidation here, pneumonia, the main bronchus will be there. If mucus plug obstructs this main bronchus, so there will be a collapse. The upper lobe may collapse. Okay, so that is one reason for collapse. One of the common cause for collapse in consolidation is mucus plug obstruction. Then you do a bronchoscopy and remove that mucus plug, then the lungs will become normal. Another reason is, suppose there is a major bronchus is there. So there is a mediastinal lymph node that obstructs the major bronchus. That also can produce collapse. Whatever it is, collapse, the interlobar fissure you can see here that has gone up. That indicates a loss of lung volume. Here if you trace the trachea, it is compressed. You can see here trachea is compressed. That is due to some mass. We don't know what it is. It is compressed. So this looks like a collapse. And if you see the rib spaces, here the rib spaces are very narrow. The same side, opposite side, you can see they are very wide. That also indicates a loss of lung volume on the right side. So that indicates right upper lobe collapse or right upper zone collapse. Upper zone, what comes? Here it comes the upper lobe. Above the interlobar fissure, it is upper lobe. Now, right mid lower zone lesion. Here you are seeing a mid lower mid and lower zone lesion. This can be middle lobe pneumonia. To know the middle, whether it is in the middle lobe or lower lobe, you have to always take a lateral view. But if the patient symptoms are like cough, breathlessness since last 1 or 2 weeks, and he is having a lesion like this, and you are seeing the air bronchogram in the lesion. Air bronchogram means inside the consolidation you can see the airway can be seen in black color. You can see here it is in black color. That is air bronchogram. So that indicates right middle lobe consolidation. Air bronchogram is a typical feature of consolidation. So that is right middle lobe consolidation. This sign is called as xyloid sign. So you can see the hard border here. You can see the diaphragm here properly. Suppose it's a lower lobe consolidation, you may not see the borders of the heart and border of the diaphragm clearly. So that is called as xyloid sign. Now this is right lower lobe pneumonia. You can see how it is different from the previous X-ray, that right mid lobe pneumonia. But when we are reading the X-ray, we have to tell it is right mid and lower zone consolidation. It is in the lower lobe because we are taking an X-ray in the lateral view and we are seeing. But you can clearly see you are not able to see the borders of the diaphragm and heart clearly. So it is in the right lower lobe. Okay. Whether it is lower lobe, upper lobe, middle lobe, we are treating the patient as a pneumonia patient. Okay. Depending on the area where we are getting the pneumonia, there may be a difference between the organism. So upper lobe organisms are mostly Klebsiella. Lower lobe organisms like this organism can be mostly gram-positive organism, but that also we cannot tell like that because a patient who is having chronic history like chronic repeated lung disease, all these things, even gram-negative organism can come here. So okay. The next X-ray, what we are seeing is a atelectasis. Atelectasis means a collapse. You can see the cardiac border is slightly pushed towards this lesion. So that means, and diaphragm also slightly pushed towards this lesion, and there is a white opacity here. So if it is a pneumonia or consolidation, hard border will never come to this side. It may be slightly pushed that side. Diaphragm may also be pushed down because of the edema. But here the lung part is collapsed, completely collapsed. That's why heart is pushed here. Suppose there is a, like this is your main this one, major bronchus. There is a lymph node or tumor here that obstructs the main bronchus. This part of the lung will collapse. When it is collapsed, that is a vacuum. The heart may move to this side, diaphragm may move upwards. Okay, so that is called as atelectasis. So that also can produce a white lesion. It can have differential diagnosis for this is lower lobe consolidation. But depending on the clinical scenario, you have to tell whether it's a consolidation or collapse. Sometimes collapse can associated with consolidation can be associated with collapse. Okay, so that also we have to keep in mind. Here, what happens is in chest X-ray, in we are seeing only in PA view. AP view, we should never comment about the heart mediastinum because I have already told the diaphragm may go up in when you are lying down. That can enlarge the heart. So never comment on the heart or cardiomegaly on AP view. Here the mediastinum is widened. From previous X-ray, you know that mediastinum is widened here. So mediastinal masses, lymph nodes, tumors, aorta, aortic enlargement, all these things can produce mediastinal enlargement. So this can be simply a thymic mass or multiple lymph nodes or metastatic lesions, tuberculosis, sarcoidosis. Sometimes aortic aneurysms can also enlarge like this. Okay, so many differential diagnoses are there for a mediastinal widening. To have a better idea of what is happening, then you have to take a CT scan. Now, I already told that when the patient is lying down, that is epi view, never comment about the cardiomegaly. When you are lying down, your diaphragm, both the diaphragm can go upwards, and that can push the heart towards up, and mediastinal enlargement is common. So that cannot be commented as a mediastinal widening. Only in PA view, you should comment about mediastinal widening, not in epi view. Especially in patients who are lying down in emergency room or ICU, we should never comment about the mediastinal widening in a AP view chest X-ray. We have to take a PA view chest X-ray to comment about mediastinal widening. So what you are seeing here is white homogeneous shadow in the lower part. Okay, see here you can see the diaphragm. Normally diaphragm comes like this. Here there is a meniscus or sign of fluid here. So you can see here fluid level here, that is increased here. So there is full of fluid here. So this looks like a pleural effusion. Pleural effusion means fluid in between the two pleuras, and this is fluid. So on percussion it will be stony dullness. Auscultation there will be reduced breath sounds. Ultrasound is a better method or better tool to pick up the fluid in X-rays. If you take a lateral X-ray in this type of minimal fluid, lateral decubitus position, that means patient will be lying down towards the right side. So when the patient lie down like this, you can see the lower part will be fluid. So nowadays we don't take that type of X-rays in emergency room. We try to do ultrasound and pick up the fluid. But whatever it is, white shadow on one side can be fluid also, pleural effusion also. Mostly pleural effusion, you can see the heart may be compressed or pushed towards the opposite side. But what happens sometimes because of malignancy, so here there is a malignant lesion, lot of fibrotic bands will be there, that can drag the heart towards the same side, and at the same time you can have fluid also. Okay, don't think that all fluids will push the heart towards the opposite side. Sometimes a malignancy induced pleural effusion can even drag the heart towards the same side. Okay, here you can see that typical example. There is a fluid, but heart is completely shifted to this side. Okay, either there is an associated collapse this side, or a tumor or a lung lesion which is dragging the heart towards the side. Now, if you are taking X-rays in ICU, the patient is lying down, so the fluid, which is normally we see pleural effusion like this, so lower part will be fluid. When you are standing up in a PA view, when you are lying down, the fluid can accumulate in the posterior part of the lung, and there will be universal haziness of the side. That looks like a collapse or consolidation on the full side, but it is fluid. Suppose you make the patient stand up and take an X-ray, fluid will be only in this part. Okay, when the patient is lying down, the fluid can spread over the posterior surface, and when you are taking an X-ray, you can get it like this. So that is very important. When an X-ray is taken in ICU, if you are seeing like this, uniform haziness of one side can be a pleural effusion. So that is very important. It looks like a complete collapse of one side. You can differentiate the collapse from pleural effusion. You see the rib spaces. Okay, here both the side rib spaces are almost equal. So that tells you that it is not a collapse. It can be pleural effusion. Now, hydropneumothorax means pleural effusion. We have already seen that there is a level of fluid, but the lateral part of the fluid is always blended. But if there is air, that occurs normally when you try to tap the fluid. So air may go inside, and that produces pneumothorax. You can see here there is a straight line down fluid top air. Okay, so that straight line tells you that this is hydropneumothorax. Normally, this occurs after fluid tapping. Here also you can see the straight line. So this is pleural effusion. We try to tap this pleural effusion. Normally, fluid will come out. Air will never enter inside. But unfortunately, if the air goes inside, it will be like a fluid level. Okay. Here you can see the pneumothorax. There is no fluid level. This is the lung area and there is no fluid level here. Okay, so hydropneumothorax is a mixture of effusion with pneumothorax. Okay. Now bronchiectasis, you can see the small rings like lesions in the multiple cavity like lesions in the lungs. So this patient will have a history of chronic cough, breathlessness, productive sputum. Sputum can have severe smell. Pseudomonas is one of the common organisms which can grow in this type of lesions. And the CT may pick up the exact lesion in the lungs. You can see small cavities. Actually, multiple small cavities are called as bronchiectasis. Okay, so that will be destruction of bronchus, and there will be lot of spaces in between lungs that can produce chronic infection in the lungs. Okay, another X-ray what we are seeing here is a pneumothorax. You can clearly see the lung outline here. That is very important. Lung outline is seen here, and here also you can see the lung outline. So air has entered inside the space and that is compressing the lung. So that is very important. This patient can have severe breathlessness. Sometimes you'll have to remove the air or sometimes you have to put ICD to remove the air continuously. Okay, so that is pneumothorax. Now emphysema and pneumothorax, you should know the difference. Here you are seeing black color throughout the lung field, and here you are seeing a compressed lung that is white in color. But the next X-ray what you are seeing is, here also you can see more black in color. Some part of the lungs are black, but this patient may give chronic history of smoking, repeated breathlessness. When you are taking an X-ray, what is a striking feature is, most striking feature is tubular heart. The lungs are expanded maximally so that lungs compresses the heart towards the center. So heart will slowly become a tube-like structure. Diaphragms are pushed down, more than 10 ribs you can see sometimes. So diaphragms are pushed down. Sometimes diaphragm will be flat. So depending on the severity, it will become even flat. And the lung area will be more black in color. You should understand that when you are taking an X-ray, the more air means more black in color. Here also more air means more black in color. So the problem in COPD is air trapping inside the alveoli. So the lung area is more black in color comparing with a normal lung. So here you can see an X-ray of COPD patient. Tubular heart, diaphragms are pushed down, and lung areas are black in color, more black in color. Now another important feature of COPD, that is the expansion of anterior posterior diameter. Okay, this is sometimes called as barrel sign. Okay, you can see normal person's AP diameter is lesser than the transverse diameter. Here it is more or less equal both sides. So that is called as barrel sign, barrel chest or barrel sign. Now pneumonia, the next important feature is, here you can see here lower zone, white homogeneous opacity. Depending on the clinical feature, it can be pneumonia or it can be collapse. Okay, suppose the patient is having a history of recent history of cough, breathlessness, productive sputum, blood tinged sputum, it can be pneumonia. But if the patient is having a history of chronic weight loss, chest pain, then it can be even collapse also. So here lymph nodes can be there, the major bronchus can be completely compressed, and this part of the lung can be collapsed. But the difference between collapse and consolidation is, suppose it is collapse, you can see the rib spaces will be more narrower than the opposite side. Heart may be slightly deviated to this side and trachea may be deviated to this side. So what you are seeing is trachea is totally deviated to this side. So trachea is totally deviated to this side. So there is a chance of collapse in this patient because you are seeing an area which is more consolidated or more white in color, this area. That can be lymph nodes. That produces a collapse consolidation on the right side. So the mediastinum is shifted towards this side, heart is shifted towards this side. So this cannot be a simple pneumonia. It can be collapse consolidation. Okay. Now, bronchopneumonia means throughout the lung fields, you are getting white non-homogeneous opacities. So, here all you can see non-homogeneous opacity. So, again depending on the clinical history, you have to make a diagnosis. Suppose this patient come with 3-4 days history of cough, breathlessness, URTA symptoms are there, then this can be viral pneumonia. So, this can be viral pneumonia. Suppose this patient is having a chronic history of like a smoker, COPD, and he is having chronic fever, weight loss, all these things, then there is a possibility of miliary tuberculosis or malignancy itself. Suppose this patient is having an acute history of fever, breathlessness since last 1 or 2 weeks, patient is deteriorating, multiple organs are involved, LFT is altered, creatinine is elevated, then this can be ARDS also. Okay. If the heart is enlarged, then it can be cardiac failure and pulmonary edema also. So depending on the clinical feature and depending on the history, when this can change. So it can become miliary tuberculosis, it can become viral pneumonia, it can become ARDS, it can become tuberculosis or simple bronchopneumonia. So all those things depends on the clinical scenario. Then cardiogenic pulmonary edema, previously we have seen ARDS. ARDS means pulmonary edema without cardiac failure, that is ARDS. But here cardiomegaly is there. If you see an echocardiogram for this patient, you can see low ejection fraction, bilateral extensive shadows over the lung, white shadows. So that can be cardiomegaly, cardiac failure with cardiogenic pulmonary edema. So clinical history is very, very important to make such diagnosis. Now the next thing is called as phantom tumor. Suppose there is cardiomegaly. So here you are seeing cardiomegaly, the large heart. You are seeing echo and EF is only 25. That is very low. Less than 50 is low. Now you are seeing a shadow like this. This is interlobar fissure. What you are seeing interlobar fissure. Water will get inside the fissure. That is pulmonary edema, and suddenly a tumor-like structure will form. Okay. So you may think that it is pneumonia. Here also you can see the interlobar fissure is edematous. So you may think that it is consolidation. If you give Lasix after half an hour, if you repeat the X-ray, this will disappear. That is because it is fluid. Okay, it is fluid in the interlobar fissure. This is called as phantom tumor or vanishing lung syndrome. Now, a patient come with acute history of fever, breathlessness in last 3-4 days, and if you are taking an X-ray like this can be viral pneumonia. A patient who is having HIV and very low CD4 count, if you are taking an X-ray like this and he is having breathlessness, it can be PCP pneumonia or fungal pneumonia. A patient who is having multi-organ dysfunction syndrome after dengue fever or leptospirosis, if you are taking an X-ray like this, it can be ARDS also. So depending on the clinical scenario, this X-ray diagnosis may change. So X-ray alone will not give you a diagnosis. Clinical syndromes are very, very important. Now another important diagnosis is tuberculosis. So we have discussed the first slide itself. The elevated interlobar fissure, that indicates a loss of lung volume. Here what you are seeing a consolidation or a white patch with a cavity that mostly goes in favor of tuberculosis. And you have to always look at the trachea. Here trachea is not deviated, but interlobar fissure has gone up. And here you are seeing a cavitatory fibrotic lesion. Okay, mostly go in favor of tuberculosis. But in tuberculosis, it's another type of differential presentation is, or different presentation is miliary mottling, small mottle appearance throughout the lung field, white patches you can see throughout the lung fields. So that indicates miliary modeling. But if same type of lesion, a patient coming with acute breathlessness since last 2-3 days, then it can be viral pneumonia, bilateral pneumonia, bronchopneumonia, because of the viral like H1N1, COVID and all. You can get like this. A patient who is having HIV infection is coming with very low CD4 count. This X-ray may indicate PCP pneumonia. So depending on the clinical scenario, here also diagnosis may change. Now we have discussed about one of the common problem in emergency room, how to read chest X-ray. We have only discussed about reading of chest X-ray. Some other day we'll discuss about other types of X-rays, CT and all. Thank you.